very much. We're okay. You know, the doctors innovating around healthcare crises is.
Can't hear you now.
Okay, how's that? That's better. Anytime you're working with healthcare systems, you're trying to convince your colleagues to rally around your cause. And I would say, at least from my standpoint, if this crisis or this epidemic of opioid issues we've been talking about today was denied that it was an infectious disease, this would be much easier. But the reality is it's much more difficult to organize this with our colleagues and staff because of the nature of this topic. So I see the evaluation of my colleagues here to the left who already demonstrated they put together various and very successful systems of different approaches on how to do this. So each of us are going to kind of go through our individual approaches to how you organize a system to approach this issue, and hopefully this will be enlightening to take questions out. Does this sound better?
Yes.
Good. I think I was going to lose my voice, but I think it's not. It's better.
Yes.
This is just an introduction of who we are at Confluence itself. We're in the middle of North Central Washington, and really we're about a 6-year-old affiliation between two older organizations, the National Medical Center Medical Group, which has been around since 1940, and it's a multi-specialty group, now going to about 300 doctors and another 148 PTs. So moderately big. This is a large but a rural setting. And Central Washington Hospital, which is a 183-bed tertiary care hospital, which it really covers all specialties, including open heart and basic cancer care. And we're about 40% primary care as a group, with 60% specialty care. We organized 6 years ago as a non-profit 501c3 that kind of encompasses both organizations. As you can tell from this map that I'm about to show you, that we cover a large swath of Washington State, about 12,000 square miles for different sites. We're organized as a physician-led organization, as a 501c3, so all layers of the organization have both a physician and non-physician leader as part of the leadership of the organization, administratively and clinically. So the challenge is we have patients with a problem that sometimes no one wants to deal with and not problem patients. And that was one of the first tenets of what we wanted to address. That this isn't a problem patient, this is patients with a problem. Patients with a patient. And the number 2 tenet with this is everyone's responsibility. We've talked a lot today about this as being the primary care responsibility, which we do think is true. The foundation of care is primary care, but we also call on our organization our specialty follows health. And in our situation, that no one's hand was closed to these patients, because that was one of the barriers we were running into, was this idea of we were getting orphan patients because a family or a physician would retire and their patients would be picked up. And so one of our policies was that you could not close new patients that had chronic pain and or you had any part of the solution. And then we would use multimodal therapy as the foundation of our treatment. So we embedded behavioral health within all the primary care in an open access model. So we have psychologists or mental health specialists in every primary care facility, even the ones you see in those tiny towns. Some of those are accessed just part of the week. They rotate through those communities as part of the rotation. And they all work in open access models. So all those behavioral specialists, if they're embedded in primary care, at least half of their day open as open access. Because we were finding it was doing us no good when they would simply fill up and they weren't available for safety of them. We also use activity-based therapy, either through formal PT or informal activity-based prescriptions advised by PT or activity-based professional, and that's tracked through functional measurement using PEG score. We need MAT prescribers available throughout primary care, and this was an ambitious list. We're trying to get MAT prescribers at every site of primary care. We finally actually actualized that goal. That was a multi-year program. We started an opioid care committee, which is a multidisciplinary team for consultation that any provider for any patient requiring either opioid or MAT therapy. This involves physicians, pharmacists, APPs, and nursing. It also involves feedback from our patient advisory council. We have patients on the council that advise us on multiple aspects of the care we provide, including opioid therapy. And they act to give advice on specific patients to providers and or run down issues related to either regulatory changes or changes in evidence-based care. They're the ones that really help stay up to date on the literature because, as multiple speakers said today, it's really challenging to stay up with both the literature and the regulatory requirements that come down the pipe. They kind of create a Reader's Digest list for us so that it's easier to hit the tops of the waves for our group to say, look, this is the top things you need to keep on top of. So you don't have to read the whole thing, and it's been very helpful. They also maintain and monitor opioid and combo drug dashboards to make sure that we know if we have high-risk patients. So that each provider has their own dashboard to know, these patients appear to have a high-risk regimen, pay attention here, and they keep on top of that. We are trying to use 90 morphine equivalent doses as our target, but it's not a mandate to stay under that. This is just a guideline to say, look, anything above that, we really like to see a care plan that's outlined and justification for doses above that. One of the things we did start was, I think the first in the state in Washington, is a drug take-back program. So we went to the powers that be and asked to be able to put secure drug take-back boxes. They're like bear boxes. If you live where I live, everyone knows what a bear box is. And so we have bear boxes basically for drug take-back. It's anonymous. Any patient can bring any drug in and dump them in the box. And they're in all of our facilities, all our maintenance facilities, as long as there's a pharmacy attached, and both in the hospital and clinic settings. This has been really helpful because in the past it was only law enforcement that could take scheduled drugs back, and that was intimidating for many patients. So we wanted to put in healthcare facilities. And today we've taken back more than 2,400 pounds of medication, all told, which we feel pretty good about because the issues there, we're trying to avoid drug diversion, particularly by youth, because that will seem to significant risk for our community. So with that, I will turn it over to, I'm going to try to do this right now. I just received instruction to Dr. Baldwin.
Great, thank you. Okay, well, I am here to share with you a program that I am intensely passionate about called the 6 Building Blocks Program. And I'm passionate about it because it's an evidence-based roadmap that comes out of practice and helps clinics and clinical organizations actually redesign the way that they manage opioid processes to improve care. And what I love about it is that it changes the environment and it allows staff and providers to do their best work. So they're able to do that. We have funding originally from the Agency for Healthcare Research and Quality. We now have funding from the Washington State Department of Health, from Olympic Communities of Health, and the National Institute of Drug Abuse to spread this program and to help develop new ways of kind of scaling up and spreading the program. Okay, well anyway, oh, no, that didn't change. All right. Totally incompetent when it comes to PCs. You need to shift your slide. What did you do? Oh, well, I hit that about 3 times, but anyway, okay. The reason that we're working with primary care is that primary care providers are the top prescribers for opioids, and so we wanted to get at the root of where the issues are in terms of opioid prescribing. And I said that, I'm pushing that button. Oh, it went, but it didn't go on mine. So that's interesting. I'll just look at this. And so the way that this came into being was actually because one of my colleagues, Michael Cartman, really the father of 6 building blocks, who I'll show you a picture of later, he had a project in which he went to practices across the country to learn from practices that were doing a bang-up job of team-based care. And when he got there, this was 8 years ago before the CDC guidelines came out, 2/3 of them were actually working on opioids, and they were applying their team-based skills to figuring out how to better care for their patients who used chronic opioids. And so we took the evidence or the information that came from these visits, and we organized that into the 6 building blocks. And so what are these 6 building blocks, and what did we learn from them? One, what were these practices doing? They all had leadership support. They all made a consensus across their organizations for more safer and more cautious opioid prescribing. They also put into place new policies, patient agreements, and then they had workflows that aligned with those, so they made sure that the work got done by folks in various roles in their clinics. And all of those were aligned with one another. Third, they figured out who their patients were that had chronic pain and that were using long-term opioid therapy. Many clinics don't even know who their patients are in these situations, and they started to track and monitor them, and they tracked and monitored the things that were in their policies that they wanted to put into place. So did they want to do urine drug testing? Did they want to calculate MED? Did they want to check the PDMP? They tracked and monitored that. And they did that so that they could offer, I hope that's the right slide, I can barely see it, planned patient-centered visits. With the tracking and monitoring system in place, they were able to plan for visits, they were able to do things in between visits and do population management. When they were about to see a patient in the clinic, they could look and see whether they were up to date on everything. If they weren't, the medical assistant could help prep. They could check the PDMP, they could order a urine drug test, they could calculate MED if they were trained appropriately, so that all of those things were in place. We've heard a lot about the comorbid conditions for these patients, so these practices also made sure that they had places that they could manage the mental health conditions, identify patients with opioid use disorder, and get them into the appropriate treatment that they needed. Oftentimes they wouldn't even think about suggesting a taper to patients until they knew that their mental health conditions were at least addressed. And finally, they measured their success. So what we did was we gathered together these 6 building blocks, and we said, well, can we apply these to new clinics? And that's where the funding from the Agency for Healthcare Research and Quality came in. So we basically tested this program. It was a 12 to 15-month supported program using practice coaching, in which we asked the sites to get together their own opioid improvement team. And these were rural clinics. These are places that are in rural locations. We did this in 6 organizations, 20 clinics in eastern Washington and central Idaho. We conducted a team building kickoff event. So we went to the clinic. We had everyone from the clinic, front desk, back end staff, providers, administrators. They came together together and they rated themselves on these 6 building blocks. They said, how are we doing? We mixed them up. They were in small groups. They started the conversation, and that's how they gained consensus. And then their opioid improvement team worked with our coaches to actually implement evidence-based best practices in opioid management around policies, patient agreements, everything that you can imagine, putting into place tracking and monitoring programs, and developing educational opportunities for staff. What did we do as a team? We basically worked with them. We provided technical assistance. We gave them resources such as model policies, patient agreements, clinic workflows, educational materials. We had quarterly action planning meetings. So they had a sense of what they wanted to accomplish. They decided what they wanted to do. But we held them accountable. We said, hey, you said we were going to do this, and they knew that we were going to come back 3 months later and say, how's that going? How's your new policy going? And so we helped them project manage what they were trying to do. We had monthly shared learning calls where they learned from one another. They talked about their successes. They talked about the problems they were having. They helped problem solve with one another. And then they also had an opportunity to participate in telepain where they could present their thorniest cases with a pain specialist and get input on those. And here's what we found. We found that the total number of patients who were using long-term opioid therapy declined, and we found that of those who continued, the proportion on high dose declined as well. And we compared that to control populations because there were declines overall, and there was a more rapid rate of decline in our clinics. But also importantly, we found that there were huge differences that were made for the staff and the providers of these clinics. The work life of these clinics changed dramatically. So one staff member said, everybody that works at this clinic says to me, do you remember how much turmoil there was around this? Well, we don't have that anymore. Or the thing that surprised me was the number of patients that once they started understanding what our standard care pathway was, they say, wow, I get it. And then a lot of them wanted to initiate a taper themselves. And the staff member said, I wasn't quite prepared for this. Or another provider who said, now that I've got a standard care pathway and there's consistency across all the providers, it's kind of like walking into an emergency room and there's an MI, there's a myocardial infarction, we know what to do. And that was just so reassuring. So I encourage you to go to our website, www.improvingopioidcare.org. You can find all of our resources there. They're available. We have a couple of published articles, including our outcomes. And the team, which is Michael Parchman on the bottom left, myself, and then our 2 fabulous practice coaches, would be happy to talk with you about practice coaching, about how to train coaches in your own environment, and you can find my email on the lower right.
Thank you, Dr. Baldwin. By the way, Dr. Baldwin, we built our program by using your 6 building blocks. That's a framework we used. It's been very, very helpful. Next, I invite Dr. Butler. Dr. Butler is my colleague in Mackey, clinic down the street, so we've been friends a long time.
Let me see if I can. So I'm Butler, I'm a family physician. I practice where it's 103 degrees today in Eastern Washington. I can throw a rock from my office and hit Stu's house. And Stu and I have been doing this together for a long time. We're formerly competitors. He is the large polyspecialty group, and I am the small MQHC in town. And together we look after basically the same populations, just in 2 different systems. Anyway, what I was asked to do today is not so much how we do things in our system, which is very similar to how Stu does it. Interesting story, in 2008, Stu and I got together and we put on a conference in Leavenworth for all of the doctors in our little valley about how we should be thinking about the management of chronic pain with opioids. And I think actually at that time we made about a 3-degree course correction on how we think about opioids and that they should not be first-line therapy and so forth. And over the last 9 years, we've now gone quite a ways away from where we were. And I think just that small course correction over time multiplies. What I was asked to talk about today actually is not how we do things inside our system, so much as how primary care providers can think about receiving patients who have been abandoned or released from, or whose provider has lost their license or their capacity to prescribe opiates. When I arrived in 1993, there were essentially three, what at that time we called pain doctors, although in retrospect they were more or less pill mills. They were people who were willing to see patients and were willing to prescribe high-dose opioids. And over time, one by one, their licenses were pulled. And 2 years ago, the final one had his license pulled. And for those in the room who aren't practitioners, the experience we have in town is essentially everybody is practicing careful medicine. And we have 2 or 3 outliers in the community who are not. And when we care for their patients as they come into the hospital, we just go, oh my goodness, how is it even possible that they're practicing this way? And we'll work hard and we'll get the patients down in the hospital and then we send them back out and they go right back to those same doctors and get put back on all their opioids. We see this in the obstetrical practice where we take them in for care, we get them tapered all the way down, they deliver their baby, they go right back and they get put back on all their opioids. So the experience then of that person leaving practice is that there is a tidal wave of what we consider, by careful, objective observation of their patients and the care they provided, a tidal wave of poorly managed patients who are now coming to us and are seeking help. I think, as Stu pointed out, as a system, we really need to make a standard that we're not allowed to say no when these people come. But from the practitioner's standpoint, this is scary. This is somebody coming to you, and you feel overwhelmed already. I don't know how many of you know physicians who feel that they've got plenty of room to accept more patients. And they're going to come and drain your psychic energy and disrupt your practice and annoy your staff, and you have a moral obligation to take care of them. Another thing that hasn't been mentioned here today enough, I don't think, is that the easiest thing to do in this population is to practice badly. It is way easier to give the patients exactly what they request and to move them on and to charge $300 and to just get them going than it is to take very good, careful care of them. And so we enter sort of a win-lose situation where, or maybe a lose-lose situation where they're miserable, the patient is miserable, and I'm miserable. And why do we want to persist in this way? So as was pointed out, very complex, very difficult, challenging situation why we are all in this room together. So anyway, what I'm going to talk about is how we might receive these patients into our practice. And the first thing that I wanted to think about, and I'm really excited that all the people spoke today and gave all the best evidence, and I wrote this up 2 years ago and I got it all right. So that's pretty cool. So the first thing is, we have time to do this well. Even though there are laws in the state of Washington that say, you shall not have people on higher than 120 milligram morphine equivalent dose without a pain consultation, even built into that law, we have 3 months to try and get a pain consultation. Now, those of you who don't live west of the mountains, it is tough getting a pain consultation in most of the state where I live. Even in all of Stu's system, he does not have anybody who's hanging a banner as a pain specialist. So, it is getting people to find a car and drive to Swedish or drive to the University of Washington to get this kind of help. So it's a challenge. The second take-home point is the first thing we need to do as primary care providers is build the patient's trust. We're going to build that trust, we're going to take the time we need, and then we're going to leverage that trust later. The last thing is, the last time I gave this talk, I think I had an hour, and this time I have 5 minutes. So on your table, I wrote all this stuff out. It's on a handout on your table. It's like the step-by-step, visit-by-visit primary care guide to what you're going to do with patients. I think we need to recognize, and I think we heard it from the patients who spoke and the advocates, when a patient loses their prescriber, they are in terror. They have hit the street and they have fear out of bounds. David Talbot used to describe people in trouble like this as having a brain on fire. And they're coming in, and they know that the first thing they have to do is convince you of how bad their pain is and how much they need their opiates. So remember the patient doesn't know us, and we have to assume that that patient is actually pretty satisfied with their care. They're going to that prescriber and getting those high-dose opiates, and in their mind, they are the victim, and that this prescriber was the only person who really understood their problem, which is why they were prescribing all of those high-dose opiates. And so they're in this state of heightened anxiety and self-righteous indignation. And so the first thing we have to do when they hit our door, after we calm ourselves down, and after we allow them to vent for some period of time to get all that energy out, is we have to let them know that we're not going to change anything today. And then what we want to do is build their trust. So we need to be able to say, you know what, I've been doing this for 25 years now. I'm really comfortable with this kind of work. I got a care team put together who's going to look after you, include psychologists and pharmacists and my partners, and let them know that they landed somewhere safe and somewhere thoughtful. And then let them know that what we need to do is go back and start from scratch. We need to review absolutely everything that's gone on before, and I was very pleased to hear several other speakers say more or less the same thing today. We have to reevaluate them, and we need to let them know that we need to practice within the standards of care. My first job is not to take away your pain. My first job is to keep you safe. My second job is to make you functional. And we have to put it in that way, because when they say, but you don't understand, doctor, I'm in pain, you can have that different conversation of, I need to keep you safe. What I learned out of today's evidence-based conference is there's really no good evidence right now on what to do with this cohort of opioid-using chronic pain patients who've been on it for a long time. But what I do know we have good evidence about is that people on higher and higher doses of opiates have a higher risk of death. To my mind, that is well established. And so if somebody comes into my practice on 500 milligram morphine equivalent dose, they are impaired. Even if they've been doing it for 10 years and they feel very much in control, I don't think we have good evidence that just because you've been doing it for 10 years, you're necessarily safe. And so we do have an obligation to keep them safe and lower those doses. So, then you got to do the work. First, you're going to keep them safe. You're going to make sure they have naloxone. It is a wonderful conversation to have with a family member, and I love it when they bring their family members with them. Here's the Narcan. Here's how you use it. And that sets a very different tenor in the room, and very frequently the family members are actually on my side because they too are scared about what's going on with these medications. Then we have to say, listen, you're not allowed to be on other concomitant sedatives, right? We have to talk to them about that, and it's been fun to sort of watch, because when people are coming on Klonopin and on clonazepam and on high-dose opiates, and you say, okay, we've got to taper one, which one should it be? They prefer to taper the opiates because they really feel they need their clonazepam. If they're on methadone, if they're on fentanyl patches, we need to think about getting them on the short-acting opioids, because it's pretty clear that the long-acting opioids are more dangerous. The initial bolus, I think we have to go through and do a complete H&P. One thing I want to point out at my table, I heard one of my table mates saying, you know what, I don't think we have time to do this in primary care. So I think it is important, if the system needs to absorb a bunch of patients like this, we better make darn sure we got time to do this. This means 30-minute visits. This means 30-minute visits every week for a month or 6 weeks, or as long as it takes to do this. So, we've got to get the H&P, all the things on this list. We want a history of what's been tried and what's worked and what hasn't. We've got to do the PEG. We've got to do the opioid risk scale. We've got to screen them for substance use disorder. We've got to screen them for depression, PTSD. We've got to look at the PMP. And I'm more and more passionate about the fact that people will come in and they'll just be pegged with chronic pain syndrome. And then people prescribe opiates for their chronic pain syndrome. I think that's entirely inappropriate. They need a diagnosis. They have ankylosing spondylitis. They have rheumatoid arthritis. They've got some other appropriate medication for opioid use. And if all you've got is fibromyalgia and chronic daily headache, and you're going to take that to a reputable pain doctor, he's going to laugh at you and tell you that we don't use opiates in those diagnoses. And so just forcing yourself to be careful about the correct diagnosis will actually help also in management. For the treatment plan, then again, we document what that active pain diagnosis is. We look for their comorbid risk factors, estimate the risk of misuse, high, moderate, or low, and then calculate the MED. And again, in Washington State, if they are at or above 120 milligrams, they need to have a pain specialist consultation, or they need to start tapering at about 3 months. That's the law. So, what we want to do is we're starting to work with these patients is to frame everything as this is another opportunity to look at everything. And we're going to repeat the diagnostics, and that goes to trust also. Here's somebody who's been on high-dose opiates for 10 years, and maybe they haven't had an MRI scan in 10 years. Get another MRI scan. You're going to be seeing this patient every month or every 3 months for the next 20 years of your practice. You know, the relative cost of repeating diagnostics is low. Again, consider referrals to see if there is any surgically treatable disease or other possibly modifiable conditions, and involve the behaviorists. How many people in this room do not have behaviorists in your practice? So that is an incredibly small proportion, which is wonderful. Because 10 years ago, nobody had psychologists in their practice, and now that we all do, that's wonderful. So, and the patient's going to say, oh, I do it. You just think it's all in my head. And so, all of us, as we're receiving new patients, have to be ready for that with the following, that we need to say, no, I'm going to be asking you to make some significant changes here, and my friend, Dr. Whitfield, is going to help you work through those challenges. We need to let them know that pain doesn't cause them to drink that alcohol. I only drink it when I'm in pain, doc. Pain doesn't cause their depression. We need to treat those things too. And that many people have comorbid emotional trauma in their history, and that opiates help you feel better if you've got adverse childhood experiences and PTSD. That sleep dysfunction makes everything worse, and our behaviors can work with you on your sleep dysfunction. And finally, in my mind, I'm thinking of all the anger, shame, grief, and the existential issues that go on in somebody who's 50 years old is not where they thought they would be in their life. I was pleased when Michelle said that her finding or bumping into central sensitization syndrome was an epiphany for her. I think it has made my life much easier to understand this and to be able to bring it to patients. And we can literally say, we've got a new understanding that we didn't have 10 years ago when you were started on opiates. And then we're going to sort of run through all the things on this list and how the behaviors can manage this. As I think Michelle actually said it, chronic pain is not a medical problem, it is a behavioral problem. In my mind, 90% behavioral. And so engaging them early, letting the patient know that this is a routine standard part of care delivered in your clinic is going to pay dividends. And then finally, talking about the non-opioid management, and on here, that is activation, 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 and Tylenol. Right? We've got to get these people moving. They don't move enough. A lot has been said about tapering already. I think the important points are it has to be individualized. You don't even mention it until the third visit. You're going to frame it in terms of safety, and you're only going to invoke the rules if you need to, and that you don't need to know this. We learned it today. There isn't great evidence around tapering yet, but we use the 10% per month. It has always worked well. Another thing that was pointed out as we were hearing all the data earlier, how is it that people can just cut off those opioids? We look at the data and it looks like people just stopped. Well, the answer is when somebody comes into my practice and they've been prescribed oxycodone in a huge dose and they've got no oxycodone in their urine, even though they told me they took it this morning, that's the person you don't re-prescribe for, right? Because they're diverting. They're not using the medication that they say they are. So I can imagine how, when you look at epidemiologic data, people look like they've been cut off in a day, where in fact, they just weren't re-prescribing. Anyway, 10% per month. The other thing is firm but empathetic tapering. How do I help people who want to quit smoking? I am firm but empathetic. How do I help people who are tapering off opioids? We're going to hold them, their feet to the fire and get them down. But if they say, you know what, my daughter is getting married this month and I have to go to Hawaii, all right, we'll hold the taper this month and we'll pick it up next time. This is a 10-year relationship you're working on. So summary, read the handout. You have the time you need to build trust and to reevaluate all their issues. You want to keep them safe by stopping the sedatives and prescribing naloxone. If they're above 120 milligrams, you got to get them in for pain consult, or you got to taper them. You got a 3-month grace period in Washington State. If they are stable on the current dose, there's some parameters around that. Get them active, involve your physical therapist, involve the behaviorist, and taper 10%-ish per month.
Thanks, Dr. Next up, Dr. Shames for the Oregon Clean Guidance.
Hi, can everyone hear me okay? It's going to be kind of speed dating. I just want to quickly just let you know who I am. Family practice doc, practiced for many years in rural Oregon. Our little clinic eventually became a federally qualified health center. I was a medical director for a while. And I've been doing public health for the last almost 20 years. I'm the health officer for Jackson County, Oregon. And I also do consulting for the Oregon Health Authority, as well as the group that a number of us who've been in this conference already work for, which is Synergy. So I'm going to talk a little bit at the 20,000-foot level. I want to talk about kind of how you organize your community, how we organized our community around issues of pain and opioid disorder management. Okay, and then also how we've been doing some of the work that sounds very similar really to what Laura-Mae's been doing in Oregon at a clinical level. Okay, I'm with you, I'm going to look over here. So, as health officer in Jackson County, it's been many years ago, it came to my attention that we were losing almost one citizen a week from opioids. And you'll see that in 2006, that coincided with the peak overdose incidents in Oregon. And so it seemed to me this was now a front burner public health issue. And the question was, what the heck are we going to do about it? So we organized all the relevant healthcare individuals in the county and ultimately in the region to come together to problem solve how we were going to deal with this. We really didn't know what the answer was. It was just pretty clear we had a big problem. So how we brought people to the table, we're a relatively small community. We all knew each other. We played on our personal relationships. We had food, we had CME, we could entice people to some extent. And the Oregon and nursing medical boards also were helpful in the sense that they were getting sanctioned docs and nurse practitioners, and it was getting people's attention. Okay, so we got people at the table, and then we started brainstorming what the problem was. And we figured out where our leadership was, and we relied on that. And we started bringing in people from outside our community. It's amazing how many people are or were in this room who were folks that ultimately helped guide us as to what was appropriate management for chronic pain, and ultimately what was appropriate management for opioid use disorder. We leveraged technology to the best extent we could. We had Zoom conferences with people from all over the country who could join us and help educate us. And every year we'd have a large-scale multi-day pain conference for our region so that everybody could get up to speed and know what best practices really were. A couple of years before the CDC guidelines, we created our own treatment guidelines, the Oregon Pain Guidance Guidelines. We were really utilizing the same information and the same experts really they were, so it wasn't very surprising that their guidelines and our guidelines match pretty well. We have a website which now is a statewide resource, OregonPainGuidance.org, and we try to keep it current. And as other folks have said, I think Malcolm said it, which is, you really have to do this on a community-wide level. Otherwise, you're playing whack-a-mole. That your clinic gets it under control, and then you have to go to that other clinic over there. So we felt it was really important to have community-wide standards of care that we could all refer to, and I think a lot of us felt that was really quite helpful. So I want to shift gears and get a little more local and talk about how you can take some of those examples and then bring it into the clinic. So the Oregon Health Authority wanted to replicate some of the work that we were doing, and some of us who were involved in Southern Oregon were part of a pain management improvement team. Ultimately, we created a consulting group. The state was tired of writing contracts for each individual one of us. So, and I think you've already heard from Michelle and from Andrew, and I think earlier you heard from Laura. So that's what New Synergy is. Let me give you an example of the work we've done. We've done this in, I don't know, a dozen or more clinics. But this one was a bit unique, and what we have here is a quite rural frontier clinic way out in Eastern Oregon, where all the docs got in trouble with DEA. So the Oregon Medical Board got involved, and the problem was if these docs ended up being sanctioned and couldn't prescribe opioids, a large swath of the state would be affected. And so the Oregon Medical Board asked us if we would come in and work with this clinic, and the clinic agreed that was a better solution than their alternative. And so we took on the project of helping this clinic kind of reestablish appropriate treatment guidelines. So here's what we did. We had an in-person meeting, just like the kind of work you did, and there's been an awful lot of cross-pollination, I must say. So what I'm going to say now is going to sound very familiar to what Laura-Mae has done. We had a meeting with all the relevant folks at the clinic, and then at that point we kind of had two parallel paths. We had a series of clinical meetings with the clinicians to find out what their concerns were, what their needs were, to bring expertise to them, and the same thing with the providers, with the support staff, so that they can understand the same basic principles of care and create some structure to the way they did pain management. So we used 6 building blocks, perhaps not exactly as intended, but we wanted to assess where the clinic was at, and a series of ones would indicate that the clinic really had no structure in place in terms of dealing with chronic pain patients. Over time, it really wasn't much more than a year, there was significant change. The clinic felt that they understood now how to create systems, how to create policies, and I think everybody started feeling much more comfortable. And the docs all became ex-waiver. The total high-dose MEDs went significantly down, and we were able to track that through the PDMP in collaboration with the Oregon Medical Board. They were able to transfer many of their really difficult patients to buprenorphine and to see firsthand what that felt like, and it gave them a tool that they found very useful. Some of the relationships that we established, I don't know if I made this clear, we use Zoom technology so we can have face-to-face meetings on a monthly basis, often less than a monthly basis, with the various staff members. So we could bring in expertise to the docs. They could present a difficult case, they could get feedback, they could be encouraged to try buprenorphine, they could come back and report that it worked really well. And I think everyone found that very useful. And ultimately the board was satisfied they'd made significant changes. The carrot and the stick worked very well in this case. But, and I do think that that's something we all ought to think about is when there's really aberrant behaviors in clinics that perhaps we could partner with the licensing boards to get an intervention that will really make this needed change. So future challenges, there's the taper dilemma that we're talking about all day today, and it's very significant. And here in Oregon, right across the river, we're dealing with an awful lot of issues around tapering and angry patients and frightened patients and frightened healthcare providers for that matter. We still have the problem of way too many pills in our community, so that we have to continue to fight the good fight. And if anybody wants to reach me, that's how you would do so.
Dr. Mackey? Okay, I'll try to keep this up.
Well, it wouldn't be your conference if we didn't have multiple IT issues, I suppose. So in the meantime, I can get going. So my name is Kate Mackey. I am a general internist. I do my clinical work at the VA in Portland, and I have an academic affiliation at OHSU. And first, I just wanted to say thank you so much for the conference organizers. I have learned so much from everyone who's been up on the stage. This has been a really wonderful meeting, and I'm very pleased to have been invited to share what we've been doing in our clinic. So our model, what I'm going to be talking about, is a little bit different in that it's a local and very grassroots effort that just came up from people working in our clinic. So what I'm going to be talking about is a group that we call our Controlled Substance Review Group. And just to set the stage, telling you a little bit about our clinic and putting this in context. So we're working in the VA system. We are the resident clinic. So we have resident providers and staff providers. We have about 55 residents who see patients on their own panel, and then we have about 14 or so staff providers. Okay. So it may be nice to come up here and say that when we were thinking about starting this group, we reviewed the evidence and we read about other models and we came up with what we thought would be the best plan, but that is actually not how it happened at all. So really, one of my friends and colleagues, Dr. Claire Ziegler, she was a recent graduate from her residency training, as was I, and she and I have been having lots of conversations about how overwhelmed we felt, trying to learn how to manage patients who have chronic pain on long-term opioids on our own panels, but also because we're a teaching clinic, trying to teach residents how to do that as well. And all of the emotions that people have talked about today, fear, compassion, really wanting to do the right thing, but not knowing what that was at all. So that was sort of the impetus for creating our group. And so Claire recruited a senior physician in our group, Dr. Tom Carr, who's worked at the VA in Portland for a long time. Some of you may know him. And she also did a survey monkey of all the staff in our clinic to assess if this is something that they would be interested in. And the answer was yes. And then after a few meetings with our leadership who were very supportive, and some work with our IT department who got a console embedded into our electronic medical record, after that we just started meeting. And so we talked a lot about our model and if this was going to be like going out and finding cases, people on high doses, and we ultimately decided this was just going to be a voluntary, informal group that we would just rely on providers bringing patients to us when they had questions about chronic pain, chronic opioid use, when and how to taper, other pain management strategies, and communicating with patients. So we started our group in October of 2015, and since then we've completed more than 150 consults. So our group is pretty informal, as I mentioned. We meet twice a month during lunch, and we usually talk about 2 cases each meeting. So here's a photo from one of our recent meetings. So really the core members of the group are me and Clara, that's Clara in the white coat there. And then we have a handful of other staff providers in our clinic who may come. And if the resident is presenting, if the patient is followed by a resident, so we ask the resident to come and present their patient. And then we work in a team-based model, so we always ask the nurse care manager on the team to attend as well. And then we are lucky to have several psychologists embedded in our clinic, so we involve them right from the beginning, as well as a pharmacist. So that's really been the core group since the very beginning. And over time, we've looped in more people. So we are physically very closely located to our pain clinic. So we started talking to that group, and we got someone from the pain clinic psychology to come over and start attending our meetings. Not too long ago, an addiction psychiatrist was hired in that group, so we recruited him to come over as well. We also have a nurse care manager who really specializes in pain management. She's been coming over as well. And then depending on the case or the patient we're talking about, we often will reach out to the patient's mental health provider. Sometimes we'll have social work coming. And we also have a suicide prevention team at the VA, and sometimes we'll ask a member of that team to attend as well. So I realize that this is a long list of all these different people, and it may seem like we're very resource rich, and this may not be a model that can be replicated in other sites. But I will say that not all of these people attend every meeting. I would say most of the time we don't have everyone in all of these groups represented. It can be like a full room, standing room only, or it can be just a handful of us. So we generally take in the approach of the show must go on, no matter who's there. And so whoever's there in the room, we talk about the case and try to do the best that we can. And so the kind of consults that we get, so it's all referrals from our primary care clinic, and we also work with a women's health clinic that's just co-located with us. And the referrals can really range very wide variability of what the consult question is. So it can be sometimes more of like a nuts and bolts, how do I taper, or what other medications should I use, or what else could I think of in terms of chronic pain management. We've talked about patients who have been on opioids for a long time. We've talked about patients who've been on opioids who are trying to taper after surgery. We've talked about patients who are not on opioids but have expressed dissatisfaction about their pain management to their PCP and have asked about being on an opioid. So really a wide spectrum. And I would say a big service that we've been providing to our group is just creating a shared space where we can talk about some of the challenging conversations that the provider has been having with the patient and get some input. So having the psychologist there in the room has been invaluable to actions. For some of the cases we'll discuss, we'll actually write down specific phrases or sentences that the psychologist is saying, like, oh, you could say this with the patient, and we'll write it down and we'll put it in the note so that the provider can refer back to that next time. So I think, at the beginning, Claire and I had a lot of anxiety, I would say, if neither one of us had any special training in chronic pain or addiction before starting this. And at the beginning, if one of our more senior colleagues wasn't there, I think we got a little nervous about what kind of recommendations we would be able to provide. But now that we've been, as a group, we've talked about so many cases together, we're really self-sufficient. So even if, let's say, the behavioral health psychologist isn't there that day, I have heard her talk about this so many times. So I could say, oh, well, Dr. Cole was here today. She would probably say blah, blah, blah. So we've really created a shared practice model. So this highlighting that the impact of our group has expanded over time. Again, we just started with a small group. We've expanded to include members from addiction medicine. We are also linking ourselves to broader facility-wide efforts aimed at opioid safety. And just recently, in January of this year, we started a Buprenorphine clinic within our clinic as well. And I think there were some barriers starting that, but I think because because we had built this network already with addiction medicine, the pain management group, mental health, it was a lot easier to start the buprenorphine clinic than I think it would have been otherwise. And our next steps include creating a tapering support group for patients. So just, I know a big interest would be how other clinics could replicate this kind of model. So here are the things that I think have been associated with our sustainability. Of all of these, I think the biggest things have been having group champions, so a consistent presence over the years of people who are promoting this group, and the collaboration across services. So just as we've heard in multiple presentations about the importance of communication with patients, I think the communication among ourselves and network building and relationship building has been the most important thing that's helped us keep going. And if you have any questions about this, you're welcome to email me.
Thank you. I want to thank all my colleagues and turn it over for questions.
We have 5 minutes for questions.
Okay, very good.
When health systems issues.
Sir?
It's actually so funny because if you know Bob, every time he talks, you say, Bob, got to hear the microphone.
So now I want you to all hear me. I'm interested in a group of patients, particularly I treat a lot of different workers. And there are prescribers that are prescribing opiates for these injured workers with their back and neck problems. And I have found that it's difficult to get them back to work when they're on opiates. Now, Suboxone is, again, an alternative for these patients. So the one group that was left out of Dr. Merrill's was the low-dose opiate users relative to injured workers who are generally not on super high doses, but they have no functional improvement on these opiates. So I don't know if anyone has had experience using buprenorphine in these groups that are taking chronic low-dose opiates.
So I have, and as I think about it, and I think about patients who have moderately significant emotional trauma that they're working with, and they have fear avoidance, or I'm sorry, they have pain avoidance and all those things, and they're, as you say, on sort of a low dose, and if you put them on 2 milligrams of buprenorphine, maybe 2 milligrams up to 3 times a day, they seem to do great. Their utilization of the healthcare system goes down. You know, it's a little difficult getting it paid for and putting the right things in the chart. I don't have any experience in injured workers, but you know, the person who was in the ER twice a month with their chronic pancreatitis, which isn't really pancreatitis, and then you put them on low-dose buprenorphine and they just stop going to the emergency room. So there is some magic in there. The way I've rationalized it is that they are in some way treating this long-standing, you know, emotional trauma that they go through.
So my question is about, I treat a lot of chronic pain patients and have done so since 2006, when we were all beginning to see the problem. And I wonder what you think about shared medical appointments. You have up there that you want to have a support group for patients who are being tapered. And at RVA, they tried that, and it really deteriorated rather quickly, and it wasn't very helpful. But I think the shared medical appointment concept might be have a different flavor than a support group, which when I attended at the VA with the veterans became just a really vitriolic, horrible period of time.
Yeah, talked about that a little bit. I appreciate the suggestion. I think we will see how it goes with the tapering support group, but I think if it doesn't go well, that's not going to be keep in mind.
And we've been doing chronic pain groups for about 14 years, and we started off just me doing groups, and then eventually we migrated them over to our psychologists. What ends up happening, it works great for the first 6 months, but after 6 months, you more or less taught them everything you can teach them. They've more or less come to the place they're going to be. We did it into sort of a 6-month curriculum. And so it's once a month for 6 months, and they work through a specified curriculum. They do have a lot of support, and they do seem to enjoy it. And I think especially some patients who might be insight challenged, when they hear it from other people who are on the same pathway, when they hear successes that other people have had, I think that's a good motivator.
So I do it a little differently. I do offer shared medical visits for pain patients once a month in my clinic as an alternative. It's a voluntary situation. And the patients who seem to gravitate to that are patients who have other chronic comorbid conditions that are significant and or are older patients because they like the social support. And 6 to 8 patients at a time that I'll see for 90 minutes in shared visit. So that is their medical visit, and that's their longitudinal care with me is through that shared visit. Going down to Sutter Health to train how to do that, but that I find it very gratifying. So it's not necessarily education. It's just that's the way we do the visit is in group. Stuart, over here. Yes.
This is actually a follow-up to what you both just answered. So in Wenatchee, when you have the providers that were prescribing high doses and they came to your clinic, what I'm wondering is, if you know somebody is bringing in that is high dose, have you ever had like an intake visit that requires mental health, social work, all of that, so that you have some clinic visits set up that is multidisciplinary, not necessarily ongoing like you described it, so that they are all, plugged in automatically with mental health and other services.
We do the way what's set up is that the way we approach patients who are at high risk because their risk factor is really high because of the dosage they're on. Then we ask that they are involved in multimodal care, involving one of the behavioral health specialists along with their clinician, their medical clinician. So in my clinic, I work with Dr. Grass, a psychologist, and basically the deal is I say, look, I can't do this alone. I put it on myself. And then I partner with Dr. Grass. We introduce ourselves at the first visit, and each visit thereafter is in oftentimes we don't see them together, but we'll see them that day because they're high risk, and that works out pretty well because it's usually uncomfortable the first day, but then because she's so good, she makes me look good, and it turns out to be they've got this core of support that's more than just one person, and I think it works out pretty well. We just try to introduce this is just the way we do things, and I think you've got a similar.
Yeah, my thought is you were saying, I think the patient needs a key contact. They need a key trusting therapeutic relationship. And so I've only ever had a one-on-one for the first visit. And then after we've established that rapport and built things, then I sort of introduce the rest of the team subsequently. So in contrast to what you're saying, where maybe they have an intake with those folks and then meet me, I feel like I need to establish the fact that they can trust me and trust my recommendations before I go there.
Let's have a hand for this great round.